Hello, and welcome everyone to our GI project presentation. Our topic is exploring the protective benefit of gastrointestinal bleeding prophylaxis in patients initiated on dual antiplatelet therapy after an acute coronary syndrome. This presentation is by Dr. Rod Woodruff, Fatima Silla, myself Gerard Huck, Dr. Zube Ekpenobi, and Dr. Robert Gu. And we are from the Internal Medicine program at Huron Valley Sinai Hospital at Commerce, Michigan. The background of this presentation alludes to the prophylaxis against stress ulcers and gastrointestinal bleeding as being one of the most inappropriately prescribed treatments in the hospital inpatient setting. Typically, the indications for a GI bleed or gastrointestinal bleeding prophylaxis typically include those at a higher risk of a GI bleed while in the inpatient setting. For example, patients who are on long-term steroid therapy, patients who are mechanically ventilated for more than 48 hours, patients who had suffered a central nervous system or burn trauma, or patients who have had a history of a GI bleed within the past year. And finally, patients who have been admitted to the ICU for more than a week or have a congenital or acquired coagulopathy typically need GI bleed prophylaxis. Despite the clear guidance to the contrary, this intervention is often treated as a general prophylactic treatment, very similar to the venous thromboembolism or VTE prophylaxis. Unfortunately, GI bleed prophylaxis is not without its risk. Using a proton pump inhibitor, for example, to achieve GI bleed prophylaxis increases the risk of hospital-acquired pneumonia, osteoporosis, and C. diff infection. Given the risks associated with this starting GI bleed prophylaxis, its indications are somewhat limited. However, we believe it is worth exploring whether expanding these indications to include patients at a high risk of bleeding due to recent initiation or antiplatelet or anticoagulation therapy is beneficial or not. So for the objectives of this study, we study the efficacy of PPIs as the main GI bleed prophylaxis for patients placed on dual antiplatelet therapy following acute coronary syndrome, for example, aspirin and Plavix or aspirin and Brilinta. Our null hypothesis is that there will be a superior net benefit to patients started on a GI bleed prophylaxis with dual antiplatelet therapy compared to those without the GI bleed prophylaxis. In addition, we expect a lower incidence of GI bleeds in patients who were to be started on dual antiplatelet therapy with GI bleed prophylaxis. The methods. We explore a primary outcome measure via retrospective cohort analysis. Our primary outcome measures included those on dual antiplatelet therapy following an ACS, or acute coronary syndrome, who suffered a significant GI bleed event requiring inpatient management within the 6 months of the acute coronary syndrome diagnosis, while on the GI bleed prophylaxis, contrasted against those without the GI bleed prophylaxis. The study involved a random selection of patients admitted to DMC Huron Valley Hospital who suffered from an acute coronary syndrome, such as an NSTEMI or a myocardial infarction or STEMI, within the past 36 months. Our cohorts include patients placed on DAPT or dual antiplatelet therapy following ACS without a proton pump inhibitor such as pantoprazole or omeprazole, and 2 patients placed on dual antiplatelet therapy following ACS who were given a PPI therapy. We excluded patients who suffered an ACS or acute coronary syndrome and expired within 12 months of their arrest. And what did our results show? So we had obtained a list of 198 random patients admitted to Detroit Medical Center Huron Valley Hospital who suffered from ACS between January 1st, 2021 and December 31st, 2022, roughly 2 years, and have a 6-month lead-out time for potential bleeding events. Of the 198 patients who suffered an ACS, 93 or 47% were placed on dual antiplatelet therapy. Among that group, 53 patients, or 57% of those patients, received moderate to high dose pantoprazole or omeprazole, while 40 patients, or 43%, did not. Among the group receiving GI bleed prophylaxis, 30.2% suffered a GI bleed within 6 months, while 37.5% of the patients without prophylaxis suffered a GI bleed in the same time frame. Discussion. We initially set up this project to explore whether there is a benefit to extending the indications for a GI bleed prophylaxis towards those placed on dual antiplatelet therapy following ACS to reduce catastrophic GI bleed events following this treatment. However, our data suggests that there is little to no significant benefit in routinely placing patients on long-term GI bleed prophylaxis following initiation of DAPT, as bleeding events between the groups are roughly equal. Again, comparing 30.2% to 37.5% without prophylaxis resulted in a bleed. The ACS cohort that suffered a GI bleed prophylaxis is about 1% less than those suffered without a prophylaxis. Our sample size is too small for this to be meaningful risk reduction, and it would only be possible to calculate a reliable NNT by expanding the scale and scope of our study in terms of size and time observed. It is to mention that significant limitations of this QI project include the absence of data regarding compliance with DAPT or with GI bleed prophylaxis on discharge, a lack of distinction between GI bleed events while inpatient versus those following discharge, as initiation on heparin drip or DOACs per ACS protocol may be a more significant contribution to GI bleed events than initiation on DAPT, and selection bias stemming from poor randomization which does not account for demographic data such as race, sex, age, and socioeconomic status, and sample bias due to the limited sample size. A lack of distinction between the varying types of P2Y12 inhibitors such as clopidogrel, prasugrel, and ticagrelor, or Plavix and Brilinta, used in this study as they hold varying levels of catastrophic GI bleed events, were only recorded if the patients as well as providers recognize them as such and presented for the hospital for treatment in the same network system as the one that was studied, as opposed to an urgent care center or an out-of-network facility. Given the above considerations, a longer, more meticulous study in a larger, more diverse patient population would be necessary before hoping to expand the indications for GI bleed prophylaxis among patients placed on DAPT following ACS.